So to move on, a man who needs no introduction, I think. I first met him 21 years ago when he was a younger man. I'm giving him an opening to say something about me later. So Dr. Rick Selby has been our medical director for quite a while, and he's the division chief for hepatobiliary and pancreatic surgery, also oversees the abdominal transplant surgeons. He's been a valuable asset, of course, to our efforts here in the hospital. So let's hear from Dr. Selby about blood conservation and thoughtful medical practice. Dr. Rick Selby.
Okay. Did you guys forget to check the weather report before you came down? I'm so surprised to see so many. You know, I remember when I came to Los Angeles back in the mid-'90s, you know, everybody, when you're young, you try to build a practice and you're out stumping all the time and giving CMEs. And I think I gave around 30 or 35 in the first year I was here. And I bet you the average attendance is about 4 or 5 people. And they were mostly old physicians that were looking to pack in their CMEs. They weren't even necessarily surgeons. You know, some of them were orthopods and some of them were internists. And so that's kind of what I was expecting this morning. It was all rainy and everything, but I'm always impressed by the sense of community that the witness community does have. And it's I have to tell you that it's inspiring to see how you interact with each other, because usually in a group that's this large and people that may not be so familiar with each other, there's always sort of a kind of a tension that's in the room, and I never sense that within the witness communities. And I have to congratulate you on your sociability and your interactiveness. So this is it possible to turn off some of the light changes? So you know, the definition of a transfusion-free program does not exist. A real definition, and that's one of the problems that I have in the field, and that's in a way that's a good problem to have because we're pioneers, and in a way that's a bad problem because there's no real mold or pattern to go by. And I would love to see, and I think that's probably what will happen, although I'm surprised it takes so long, but I would love to see the evolution of transfusion-free medical and surgical practice have more of a stricter definition for some purposes, and that I think that would be reassuring to the community, and I think it would be targets for internal targets for hospitals that want to develop a program. So since it's such a loose definition, I'll try and give it some form from the way that we see it, the way that we have seen it as we've evolved into it. And in its rawest form, I would say that it involves restricting any blood use, any major fractions to any patient. And in its more sophisticated description, I would say that really it's a technology and a programmatic service that ought to be offered to all patients. And I think that's where I think that blood conservation idea, thanks to the witnesses, is an idea that initially just patients were evolving into, but now I think hospital systems and governments are all evolving into it also. So it's really in the forefront of healthcare costs. It's in the forefront of good medical practice, and since we're so familiar with it, comfortable with it, I'm going to show you how we evolved into it and how what I think the current state of the art of this medical practice really is and should be. So, where's the clicker? Oh, the mouse does it? Okay. So for those of you who have seen the timeline, I'm sorry, but it serves to really give you some perspective on the linearity of how the program has evolved, and then hopefully you'll see the three-dimensional part of it too. So in the beginning, this basically just came from a surgical practice, an individual surgical practice or several different physicians who said, well, we think we can do this witness patient without blood. And lo and behold, they were successful. It didn't have much method, it didn't have much quality control, but maybe it had good surgical skills. So whenever I had some experience with dealing with witness patients when I was at the University of Pittsburgh. We had done 4 cadaveric transplants, liver transplants on witnesses that had gone well, and Dr. Hector Ramos, who's in our faculty, wrote those up probably 30 years ago. But like many programs that develop, they start at a very low level and they're cobbled together from below rather than being highly structured and grow from above. So that's how ours was, and I think that the hospital, if Tenet had any wisdom in its development here, that they had wisdom enough to say, well, there's potential patient volume, and there's a new niche in terms of a surgical practice. So they took a chance on both me and Randy way back in the late 1990s, and so Randy became the formal liaison to the community and helped develop the program from the very inception. So, and I think, we were, I guess you could say this was a little bit ambition, but somehow back in those days, it was a little bit easier to get organs for patients, and so we decided that we thought we would be able to transplant some witness patients successfully, and I'll describe how that went in just a little bit, but there, obviously, in order to be successful with an elective Jehovah's Witness practice, it's a little bit different than being successful with an emergency problem. So, and that's something that's very important up front. So, if you're taking care of witnesses, what you don't want, if you're doing elective surgery, is to find yourself in a situation where you have an emergency hemorrhage problem. So that I think is the key to managing patients who are going to need a really big operation, or an operation that you might lose 2 or 3 or even 5 units of blood. You better have a strategy that is going to say you're going to be able to care for that patient when the blood loss gets excessive. Having said that, I would say that most of the witness patients that we take care of are elective surgical patients. They're not emergency problems. Emergency problems, when they come to us, have generally happened on the outside, and now we're faced with, okay, how are we going to be able to manage that? And that's a completely different strategy. So the ones that I'm talking about here were patients that, even though they have severely progressed disease, we're still talking about doing elective surgery on those patients, or semi-elective. So we had some ability to plan for a big operation. So the very first ones that we did here were actually living donors, and you'd say, well, geez, how can you plan a surgery? Well, with living donors, you can plan it, because you set a date, you've got a donor, and now the whole idea is to get the patients ready. And by getting them ready, it means making sure that they'll take acute normal bulimic hemodilution, that they're augmented maximally, and so forth. So at this point, this is close to 2000. At this point, we said, well, the next step in our program is going to be not just the accumulation of patients, but having a cadre of surgeons who are skilled in both the technical practice, the intraoperative practice, and who are also familiar with the mores and the creeds that the witnesses have, and will be sensitive to any of those. And so that's when So that's when we said, well, we've got it down. We, meaning our own service, we felt like, okay, we have a practice that is successful for us in the operating room. We know how to do that part. We know how to use cell salvage and A&H, and we know how to sign the patients up. But how do we actually build an environment for the patients that is broader than just our own practice? And so, we started from the outside, and then we worked towards the inside, so that whenever in this ideal program, the way that we would have it is that we have liaisons that work at CAC, and they're uniquely positioned so that they might get patients from the HLC, they might get patients directly, and they might get patients from a referring MD. It also exists that the referring MD might just send a patient to the surgeon, or the HLC might send a patient to the surgeon. And the risk, I think, for the patients and all that is if they go directly to the surgeon that's going to do the case. In the first place, that may not be a surgeon that our internal program is comfortable with. And I don't want to lead you into thinking that there aren't surgeons here that we're uncomfortable with, but the truth is that for the purposes of the witness, there are surgeons here that are either resistant or uninformed, and it wouldn't be our pick. And so part of being in this program is to be discriminating about which of the surgeons have the surgical ability and which ones have the personal ability and which ones are willing to take the time to understand the witness practice and abide by that. So if I were to say probably our biggest struggle with that interface between us and physicians who we don't consider to be quite up to speed regarding practice, it is that arena. So most of the patients who actually come in to us come in through the program in standard pathways. It's probably 75 or 80%. The other 20-25% will be a direct send, and then we just have to deal with it. So that's where we see a lot of our cultural fallouts in particular, and I'm sure that all of you are familiar with that, the surgeon who somehow wants to stick it to the patient and make sure that it's very difficult and shows that they aren't supportive or sympathetic with witness needs. So in any case, if we get it in the right way, then we can go through the critical pathways in the program. And I think the critical pathways, once you have the technical parts of the operation down, it's really the critical pathways that become key to the success of the program, because the critical pathways are what we try and teach to residents, to other physicians, surgeons, anesthesiologists, nurses. And the critical pathways are things that give an administrative registration for the patients. And so now you're getting the idea that, okay, you've got a very stepwise method for how patients come into the program and how they march through the program. And the success in the program, to a large part, depends upon this non-medical throughput. This is just administration. So just as a brief reminder, we're seafoam green, and that's how we designate the charts. And patients come in through several different portals, but somewhere when they come in through an admitting function, they get registered as a transfusion-free patient. There are all these special forms to sign. One that you will not take blood, and this is an old slide here that says it has a blood designation at the top, and now we have a banner bar on the new electronic medical record, but just to show you that there's an administrative designation for patients. And then most importantly, this is probably very similar to the advanced directives that most patients have, but this is the formal process that when patients come in, they sign as yes or no to the minor blood fractions. It's a no to all the major blood fractions, but here you've got a list of 15 things that you might not even think about if you had to pull it up in your head, but they all come to pass when patients are considered for operative services. So whether it's albumin and epidural blood patch, tagging studies, dialysis, heart-lung machine, topical antiprocoagulants, so all those things we register, we record as being accepted or refused for the patient. Cell salvage, acute normal bulimic hemodilution, and we keep a copy of that in the operating room when we're going through it, because the questions do come up. So I think that registration process is extremely important, and it helps us key in. Huh? Yeah, there's a few gray hairs there, but anyway, but even in spite of the fact that this is something that we like to make as rigid as possible, and like anything, when it gets too rigid, there's little fractures that appear. So we see violations in this sometimes, that's part of our quality control is to recheck your own systems and are your processes working or not, and where does it fall out and what happened, and where does the education need to happen, or where does the peer review need to happen. So in any case, we do see fallouts from this. Fortunately, we've never seen, that I have any knowledge of, any major blood fraction fallouts, but we had one instance of an albumin that was transfused in the face of the patient's denial. But most often what we have is cultural fallouts. A wayward anesthesiologist or an uninformed respiratory tech or a phlebotomist that comes up and draws blood. Maybe they draw a type and cross or a type and screen. And those things are generally not harmful to the patient, but they scare the patient, and they instill a feeling of insecurity, like, well, maybe this isn't the crackerjack place that I thought it was. And so those we try to respond to in an appropriate way. It's not over the top kind of response, but at the same time, and I think, you know, that whenever you build something that depends upon a fairly rigid internal structure, you're going to be vulnerable to new people coming in and going, and you know, we try to give the patients as much reassurance as possible, but there's never enough reassurance. So I think what our dedication in this regard is that we will have ongoing maintenance of these processes. They change a little bit, not too much anymore, but it's important to recognize where they fall out. Ultimately, what we would like is a module that physicians take whenever they come in for credentialing, and they take that module, and then that is an educational process, and maybe you take it every time you get re-credentialed. That may be a little bit too ambitious, but we do feel like that for people for the surgeons and non-surgical physicians that are on this panel that we rely on, they ought to have some kind of ongoing educational process. There should be one for the residents, and gradually over time, you know, sometimes it's eons, but gradually over time, the process becomes recognized, the sensitivity, the cultural sensitivities become innate, and we don't have to fight it anymore. But I'm sure you guys have been probably fighting it for most of your own lives, so it's not unfamiliar. So anyway, so in our critical pathways, and I think this is really important, in our critical pathways, we got the process, and then we've got the two real anchors that we have against the risks of hemorrhage are cell salvage and A&H. Both of those are personal choice. I would say that for the witness population that comes in for surgery, it's probably 95+% that are willing. You know, after Randy or Alex has explained it, it's probably around 95%. But I will tell you that for big time surgery, we really rely on those things. And so it provides us with a cushion of safety that is, you know, I'll show you in just a minute, but you'll see what's possible. So in the critical pathways that we have, you saw all the modifiers in the intake pathway. This with all the tiny writing up here is actually, this is nice because whenever a witness comes in and is scheduled for surgery, that announcement goes out to a distribution list. So here this patient's going to get a partial glossectomy, a modified radical neck dissection, and all these people are now told that this is going to happen on whatever date that might be. So that's kind of an alert. It doesn't demand a response, but it's just, you know, if we need to go back and look at a record of how many times we notified of a surgery and who was notified, oh, thanks. Then this is what it is. Oops. So this is, I wanted to show a few clinical slides, because I don't know how many of you have seen them, but the point of the clinical slides is that the key, the absolute key to a successful transfusion-free surgery in witness or non-witness depends upon the creation of a deliberate anemia in the operating room. That's what it hangs on. So we're going to deliberately take down people's hemoglobin as we take off whole blood and keep it in line with the patient. And that, you know, it's as simple as that. And it could be done on every patient for big cases. It should be done on every patient for big cases. And so the question is, okay, if you do that to a patient, and you do it slowly, so it's not like you're bloodletting him, and then an hour later you give him back some fluid. You're actually taking off whole blood, and as you're taking off blood, you're running in balanced salt solution. So you're keeping the patient's volume the same, but as you're dropping the whole blood out, you're going to be dropping their hemoglobin, and that's it. That's, if you, in a nutshell, that is the strategy. The brilliant strategy that is basically a one-liner. We're going to make patients anemic deliberately. How safe is that? So thanks to the witness population, we have a perfect control. So we have a lot of data on how safe it is to be anemic. So most hospitals have what they call a transfusion trigger. So above which they recommend not giving blood for non-witness patients. And that used to be that number was 10, a hemoglobin of 10, and now it's 7, which doesn't mean that when you hit 7 you give them blood. It means don't give them blood before they hit 7. And if they fall below 7, then in a non-witness patient, of course, then if they're symptomatic, either they have a powerful tachycardia or their blood pressures are low, then you can consider transfusing a non-witness patient. So that's that fact that that transfusion trigger has dropped by 3 grams of hemoglobin in the last 10 years is a statement that now there's broad acceptance by the American Association of Blood Banking and all hospital credentialing committees that this is a safe process. So this particular study took 11 healthy patients and 20 volunteers, and normal volemic hemodilution just means you pull off the blood and you keep them with a good volume. You don't let all the volume go away, but most of it now becomes salt solution rather than blood, and you're dropping the hemoglobin from a value of 13 down to a value of 5. And you're going to see what that does to the patient. And so you're reading this graph from right to left, and so we're starting at 14 and we're going down to 5. And these functions here are blood pressure, heart rate, and oxygen delivery. And that's it. So the whole idea is if you drop the hemoglobin, what kind of response are you going to get from the body? So what you get is you get the heart rate goes up, the cardiac index goes up, and the stroke volume index, so the strength with which the heart pumps, goes up. And in patients to whom this happens, they tolerate it really well until they get to a hemoglobin of around 5 or so. So you don't lose anything in terms of overall oxygen delivery. You just stimulate the mechanisms to adapt to it. So, it's not magical science. It's so easy to do, and yet surprisingly it's done so infrequently in any patient. So this is an old slide from the American Society of Hematology, and it looked at the survival of patients, and again, these were probably almost all witnesses, as you fell below a hemoglobin of 7. So here's 6 to 7, 5 to 6, 4 to 5, 3 to 4, and 2.5 to 3. And you can see that from 6 to 7 it's 100%, from 5 to 6 it's 100%, from 4 to 5 it was 90%, from 3 to 4 was 82%, and from 2.5 to 3 it was 86%. So there's a message there, and in our own experience, when the lowest that I've seen, we've had 2 patients who had live donor liver transplants that were witnesses that were between 2 and 3. Both of them survived. In fact, one of them we actually took to the operating room for peritonitis to need an operation for abscess drainage with a fungal organism, and she survived. And a lot of this depends upon the rate at which you have your hemoglobin drop. So if it's a sudden drop from 14 down to 2 to 3, you're probably going to lose the patient. But if you drop slowly, there are adaptive mechanisms that happen for these patients, and management strategies can usually save these patients. But the whole idea is we're generally not working in the range of 2 to 3 and 3 to 4. We're really talking about how, if you were to give patients ANH, most of the time we stop at a hemoglobin of 10, so we'll take them from 14 to 10, and we'll have 2 units, probably 600-700 cc's of blood available. that it can be reinfused slowly into the patient. So that's our margin of safety, that 600 to 800 cc's of blood. You can do that on almost every patient if they start off with a normal hemoglobin. The average transfusion in a non-witness patient, the average transfusion in patients that get transfused is 1 to 2 units. So if your average takeoff is the same amount, and it becomes a wash. So this is the ANH. You're taking off whole blood from the neck, and we usually do it by gravity. And for the witness patients, that stays in line with the circulation in the body, but it just gets reinfused at a very slow rate. So this is a non-witness patient, but here's 2 units. And just to tell you that we do the ANH, our own service does the ANH on every patient, not just witnesses. Every patient that has a big operation, not every patient. And I like this slide. This is an old slide, but it kind of is proof of the concept of what's possible if you manage it right. So these were live donor liver transplant patients. These were transfusion-free, the number's 8. These were transfusion eligible, the number is 30. And at this point we've done, I think, somewhere around 300 live donor liver transplants. So, and these are the recipients. This isn't the donor. So the estimated blood loss, the range was 300 to 3,000 cc's, and just for perspective, most of us have about 5,500 cc's of blood. So this is half the blood volume or a little bit more. And in the non-witness patients, it was 500 to 5,000. And this is really interesting because in the witnesses, they all had ANH. The volume of blood that they had taken off went from 2 units to 7 units of blood. So what does that mean? So if you have 7 units and the average unit's about 400 cc's, that's 2,800 cc's of blood that you've got hanging around waiting to be reinfused back into the patient. And so you'd say, well, geez, if you're taking off that much blood, how do you manage that patient when you pull it all off? First of all, you've got to augment them appropriately. So these patients had planned augmentation. We got them up to a hemoglobin of around 17 or 18 ahead of time because we knew this was going to be a big operation. So this is the preoperative planning for margin of safety for a really, really likely to lose a lot of blood. And we knew he was going to lose a lot of blood. So he had the 7 units. It was all given, it's all given back at the end of the case, and he ended up with a hemoglobin of around 10 or 11 at the end of the procedure. And he did very well. So if you can do it on a liver transplant patient, which typically have, a lot of reasons to bleed, not just the liver is cirrhotic, but they also have coagulation disturbances, and they have platelet problems, and so forth. So if you can do it on the witness patients, then why is that not achievable in almost every patient that has elective surgery? And the truth is that it is, and that's the secret sauce here. Is that if you do it right on elective surgical procedures, you can get almost any patient through it. I don't want to promise that for every patient, but I'll show you that our data is really quite good. So. And then, the bonus is if you did 1,000 patients, 1,000 procedures where you took off a unit of 2 units of ANH, and then in your control population, you took off the ANH, you took off the same equivalent, the cost would be 20 grand here and 2 million here. And that number is probably achievable for most major hospitals every year. That's what's shocking about it. And then the cell salvage, I think, also becomes important, particularly, I did this in there twice, particularly in the witness patient, it becomes important. So now you figure, okay, you've got cell salvage and the ANH going. The ANH is whole blood. So again, when you take off whole blood, you're taking off clotting factors, and you're taking off all the coagulation proteins and the red cell mass. And so you've got the whole medulla there, and it's waiting to be given back. So you figure, okay, well, if you're saving that and then you give it back later, you may be approaching a normal platelet count and a normal coagulation factor and a slightly anemic red cell mass, and that's what it is. And it's not complicated. It just really isn't. So then we started to preach to the anesthesiologist, because you need the anesthesiologist to really buy into this, because they have to put the line in, draw off the blood, manage the blood when it comes out of the body, and then reinfuse it at a more rapid rate when the time is right. So you need them to understand. Unfortunately, and this may be the biggest hindrance of all here, there's no billing code for A&H. So it doesn't enjoy the popularity that I wish it enjoyed in the non-witness population. For the witnesses, we do it because it's a requirement. But for the non-witnesses, you know, the next thing, as soon as they give it a billing code, then we're going to have an onslaught of people they just have to have A&H, right? Okay, so over the years, our academic group, has really focused on the witness population as a science. And so I think our total publications now, we have about 47 major peer-reviewed articles that we've written, you know, in adults and kids and donors and recipients. And so I think that's an important part of you know, getting the message out, and it's reassuring for patients to see that, okay, well, these guys know what they're talking about. They've written about it. And I think the next article that we have the world's biggest experience in kidney transplant in witnesses and the world's biggest experience in liver transplants in witnesses. But what we haven't published is our overall experience in witnesses for 27 years, because it's not just me and Randy and Alex and the surgeons in my division and the anesthesiologists that work with us. It's really the whole institution. And again, I'm not saying that everybody that does orthopedics or ENT or GYN that does the big operations is part of this group, but for every specialty, we have somebody who I consider a mini expert on management in the witness patients, who understands A&H, who's not going to alienate the families or the liaisons. So for us, that's the nidus, that's the crystal around which you build a whole system. To have somebody that's dedicated in every specialty. So, and then we started tracking the data. We've been tracking the data forever and ever. But I'll talk a little bit more about the data in just a minute. How am I doing for time? Okay. So I wrote this slide back in 2013 when Sabin came here and we presented. Some of you guys may have seen it already, but the whole idea is that, you know, there are certain procedures, hernia repairs, appendectomies, bowel obstructions, you know, simple gynecologic procedures, and Bitzels on the neck that aren't going to need A&H and aren't going to need a strategy. And then there's these other things that you all are probably familiar with, where patients are nervous because they're going to need to have the testicle removed, and they've got to have all the lymph nodes taken out of the mid part of the abdomen, a liver resection and a lung resection, and they're nervous and you're nervous, and so in the field of major surgery, there's probably about 20 procedures, not 200, but 20, where your expectation of major blood loss, meaning somewhere around 500 cc's or above, in a patient with a normal hemoglobin, is going to challenge your management strategy. So, excuse me. So we went through all the different divisions and service lines to try and cull out what we consider to be those procedures, and then the ones that were likely to lose a lot of blood. And then we looked at our historical experience in this hospital for how those patients did, you know, how many of them we did and how they did. So just, you know, for our service, we're hepatobiliary non-transplant part of it. Lobectomies is half the liver, trisegmentectomies is 3/4, Whipples is head of the pancreas, distal pancreatectomy, and retroperitoneal sarcomas. Those are the kinds of patients that we're interested in saying, well, we need to get this patient plugged into the operative management. For foregut, it's taking out the esophagus or radical gastrectomy. For the colon, it's abdominal perineal resections, which is basically taking out the rectum and sometimes the anus, and reconstructions in the pelvic floor. For heart service, cabbages, valves, these are non-transplants again. For the thoracic service, partial lobectomies or whole lung. For the vascular service, open abdominal aneurysm repair or ruptured aneurysm repair. For neurosurgery, craniectomy, spinal fusions, and ortho, I've neglected to put in there the big spinal cases. That may be the biggest ones of all, the ones where you're doing spinal fusions or rodding a spine. Some of those get really quite bloody. Orthopedics is, we do a lot of total knees and a lot of total hips, and they usually don't lose that much blood in the operating room, but they'll lose a lot of blood post-op in the drains, especially the redo, total knee, total hip. Radical hysterectomy for GYN, ENT, some of the mucosal flaps and radical necks. And for urology, they do a lot of the RP-LND, the retroperitoneal lymph node dissection, open prostates, radical cystectomies. And so here are the actual N numbers, and this data is a little bit old, I'm embarrassed to say, but we haven't slowed down. The data is like probably 2 to 3 years old in terms of the numbers. But you get the theme. You'll get the theme. So heart transplant, at this point there were 13 cabbages, 21 valve replacements, 2 cardiac resections, 4 pneumonectomies or lobectomies, diaphragm hernia repair, 4. For the orthopedics, 46 total knees, 38 total hips, 11 redo, and 16 redo of knee and hip. Total hysterectomies, 24. So you get the idea. Radical cystectomy, radical prostatectomy, the retroperitoneal lymph node dissection, gastrectomy, gastric bypass, Nissen, colectomy, and so forth. So as you march through these, the cervical spinal fusion, 28, lumbar spinal fusion, 31, transsphenoidal pituitary, 25, carotid endarterectomies, 3 open AAAs, radical neck, sinusectomies, mandibulectomies. And this is our service. I put ours in beautiful colors because I don't think there's any service that's probably more challenging than a cadaveric liver transplant on an adult. And those are the ones where the living donors, those are elective, and so you can really get ready for those. For the cadaveric, they come when they come. You may have a platelet count of 25,000 and so forth. So in all this group, my service had the most mortalities. We were the most prepared, and we had the most mortalities. And all those mortalities, we lost 1 kidney, but essentially we lost half of the not quite half, 66. So we lost 1/3 of the cadaveric adult livers, and those were basically, the more progressed the liver disease, the more difficult it is. So when we got a chance to prepare the living donor livers, we had a 100% survival in 25 patients. And this is adults, this is peds, we had 100% survival in 5 kids. And the cadaveric peds, and those we get offers on much earlier in cadaveric transplant in children because they get a higher priority. So they all survive. So this is the area where, we're not going to ever do any better than this, especially given the climate of organ offers when they come in terms of the stage of disease of the patient. So this is going to be a fixed number. We're never going to be able to win on this. Or we're not going to be able to win with a blue ribbon anyway. Major liver resections, 51. We lost 1 patient who actually, I think, her final hemoglobin is around 1. And 100% in 18 patients with pancreatic resection. So this is the rainbow of big surgical cases in a major tertiary and quaternary hospital with witness strategies applied. So it's such a strong message that we have to get it out. We have to update all of our statistics. Again, these are, except for the cadaveric adult transplants, these are essentially elective, well, maybe the peds too, but they're essentially pretty much elective surgeries. And so we've got planning opportunities on these patients. Now, what I don't have is I don't have all of the patients who came in as we haven't called these out, but I think it's something that we should do is look at the ones who come in, they've been bleeding on the outside for 3 weeks, they come in, their hemoglobin's 5, and we actually save them. But I think we actually do quite well, or the ruptured thoracic aortic aneurysms, and how we've done on those. I mean, we do lose some of those patients. It's just sometimes the handicap is just too high. They're either they get transferred late after they've been watched on the outside for 2 or 3 or 4 hemoglobin point drops, and then some of them it's just beyond control. But I would say that this elective practice is most of what we see. So I just wanted to show you, just for those of you who've never seen a living donor liver transplant, it's always nice to have a break of too much talking and just look at some pictures. So this is a liver that's split in half, and we do these quite well here. We don't have very much bleeding. This is the artery to the right side. So this is the right lobe of the liver, and this is the left lobe, and it's not completely cut in half, but it's getting close. The bile duct is up. I can't even see it myself. It should be a little bit yellow there. This is the artery to the right side. The artery to the left side is also retained. You can't see it, and there's the veins that come in or go to both sides. This is a cirrhotic liver being taken out of the recipient. So that's what cirrhosis is. You get these nodules based on scar tissue that's kind of crunched up the liver. And this is probably one of the sexiest things that we did in our practice here. I'm so proud of this, I couldn't even begin to tell you. The liver, this vein right here used to go all the way through the liver that we just took out. And so this, I don't know if you've ever heard of a portacaval shunt, but there's 2 separate venous circulations. There's the venous blood that comes up through the liver from the guts, and then there's the venous blood that comes up from the legs. Those don't have a common channel. This blood that comes from the guts, we normally clamp this vein, and then the vein really builds up in the guts. But instead, we took this vein out of the left lobe of the liver, and we put it into the vena cava just below the heart in order to divert all that blood while we're slowly sewing in this piece of liver over here. So this is a portacaval shunt that we invented. Nobody ever did it before, and it's basically just a stabilizing temporary shunt of the blood that came up from the colon and the pancreas and the stomach and the spleen, and we reroute it all, and it was just so cool. So this is what it looks like when it's open. So if you can kind of conceive of this vein that's going up and being diverted up here, this is the right-sided draining vein that we're going to plug into the liver, but this is all the blood draining from the intestines. And so here's the blood coming up from the intestine, it's going here. This is what we're going to plug into the right side of the liver. So this is flowing like a garden hose. It's probably 2 or 3 liters a minute. Can you see over there? It's kind of hard to see how. Here, I'll give you a little assist. See it? It's so good you just have to see it. I'll leave it up here for pictures. So anyway, so now we're doing this is the face of the liver here that's going in, the half of the liver. And this is that portal, the blood from the intestines going up, and it's on the freeway here up to the heart. And this is now the new connection between the old right portal vein and the new right portal vein of the liver. And now, once we've got the flow into here, we're going to clamp this one off. We don't need this anymore. It was just a detour for a couple of hours. And so now all the blood's going here into the liver, and it's been restored. And this is one of the kids. They look so much better so fast. They look within 2 or 3 days they look like new kids. So this one is belly's full of fluid, and there's not much muscle mass. And then this is a little girl when she was a couple years old. This is her mom, her grandmother actually was a donor. So So then, after having proved the concept and trying to promote the concept internally, that it can be done, and almost trying to mandate that the A&H and the cell salvage be done on not just witnesses but non-witnesses, we tracked our data, and then we have participated in the hospital committee structures. And in general, physicians are pretty much knuckleheads, and they don't want to change their practice. And if you get them involved in a committee, then you get a lot of resistance. But eventually, if you persist long enough, you'll end up winning people over. And I think we're getting to that point. I wouldn't say that it's we're not all rooting for the same team all the time. What we would like to do is have a credentialing module that basically forces new applying physicians to take it and get just understand patient blood management. What we have right now, and Randy's going to talk about that, right? We have an attestation statement that I'll leave up to him. So this is kind of a voluntary agreement to participate within the program. But, you know, I'm sure that many of you have fought the wars on the outside with referring physicians, and a lot of time you're trying to defend your patient's belief with a doctor that, you know, doesn't want to really discuss it. So this is basically what we're trying to do is get compliance with practices within the program internally. That's all we want. We want them to open their mind, you know, try to understand everything that we're talking about, and try to understand the processes and the methods. And that's what we're looking for. So we want to do, I'm going to kind of go through this real quick, but the reason that we want to do it on non-witness patients as well is, other than the fact that it costs less, it's also, if you get transfused, it's not good for the immune system. And there's a lot of studies on infections. This is an orthopedic study, and looking at post-operative infection after transfusion and comparing to patients who didn't get transfused. And the evidence is really quite overwhelming. It's been published again and again and again and again. It's been in New England Journal, it's been in Nature, all the major journals, and all the different subspecialty journals. So I'll just tell you, this is a likelihood, you know, this is a rate of infection in 437 patients that got transfused versus those that didn't. And the adjusted risk of getting infection versus not is 1.35. The adjusted risk of a pneumonia is 1.5, meaning that if you get transfused, you're 1.5 times as likely to get pneumonia, or 1.35 times as likely to get a bacterial infection. If you had colon cancer and you get resected, 39% of the transfused got an infection post-op, and only 24% of the non-transfused. And the risk goes up the more blood you get. And if you look at you know, 13,000 patients who were studied, not quite half, 5,000 got a transfusion, 7,900 did not get a transfusion. These weren't all witnesses, but just looking at an infection rates, the odds ratio was 3.5 times as likely to get an infection post-op if you got transfused. This is probably my favorite. I don't know if you guys have heard of C. diff, but it's a bacterial infection in the colon. Everybody thinks it's from too much antibiotic use, and you get an overgrowth of bacteria. But the most significant variable in all this, when they analyzed multiple variables, was blood product transfusion. The odds ratio of getting an infection of a C. diff infection post-op was 3.3 times as if you compared to those who didn't get a transfusion. So anyway, that data just is all over the place. The slides I'm going to show you now are our newest run at quality control. And this is the stuff that is new since the last time, I think in Pasadena, we had given the last presentation. Some of you were probably there. But what we've done with Randy and Alex and a number of other people on the committee is we have established a data tracking system that occurs in real time. So it occurs in the operating. We had a very difficult time trying to extract data from the medical record on just the operative event. We were just concerned about what happened in the operating room. Sometimes if you really look hard, you can find that data on an individual patient, but it's so hard because it's not assembled as one unit worth of data. So what we ask for is what they call a surgical pause, which happens at the beginning of every case normally, where you identify the patient, you identify the side of that you're going to operate on, you identify what the surgery is going to be, you check the medical record number, make sure you got the right patient. And so what we wanted a similar pause, or the concept of a pause, where we pulled down transfusion data or blood loss data or cell saver or ANH and against the type of procedure. And so we started doing this in 2014. And so what happens is the circulator in the operating room, so that's a nurse, has a bunch of screenshots. You probably can't see these, but you know, did the patient go to an anemia management program? In other words, did they get augmented on the outside? What was the CBC and what was the date? What was the pro-time or the INR, the pre-op hematocrit, pre-op hemoglobin, type and screen performed or type and cross performed? Did the patient give pre-op autologous donation, which wouldn't apply to the witnesses, but a significant, not a significant number, it's actually a small number, but some patients will be told by their doctor that they need to donate. It goes to the blood bank. I'm sure you all are familiar with it because it's certainly not part of the witness strategy. But the truth is that a lot of that blood gets discarded anyway, so it's not very effective in our hospital system. Did they get, did they get acute normal volume hemodilution? What was the blood loss? Did they get any cryoprecipitator plasma and so forth? So now we have data on about, and we were doing it actually on almost all of the major surgical procedures. So we were skipping the cystoscopies and the arthroscopies. But everything else that I showed you, all those patients, and even things like appendectomy and bowel obstruction, they were all getting it. So we now have 35,000 patient data to analyze, and with the help of the Value Improvement Office and some of the systems analysts that we have, we've been able to crunch that data so that we can, within a fairly short period of time, like 1 minute, you could say, okay, how many of the patients who had a nephrectomy for the time period from 2014 to 2018, how many of them came to the operating room anemic, and how many of them came with severe anemia, and how many of them had ANH, and who was the anesthesiologist that did the ANH? So the data that's available to us now is quite impressive, and so now we've got some targets, so we can target how many of the anesthesiologists didn't ever use ANH over that 4-year time period? Who were the ones that used it on almost all the cases? What service lines really need work on their 1-unit transfusion problem in patients who don't come anemic? So now we can look at, as I said, the anesthesiologist and ANH utilization. You could even get nasty and look at the blood loss by surgeon per case, which we probably won't do. Blood utilization by service line. So this is hospital data. Some of this data will be applicable for the oversighting agencies like JCO. We can look at ANH utilization by anesthesia and by the department, transfusion guideline adherence. So it just opens up a completely new world, not just for the witnesses, but for patient blood management as well. So we see this as a most significant step, but no more important than the processes or the procedures that happen in the operating room. And so now, after having put all this together, we think that we finally are a mature program by our own definition. And we also think that this ought to be the cookie cutter, or something like this ought to be the cookie cutter to get certification as an advanced patient blood management transfusion-free surgery program. So all that. So if you looked at the pillars of all this, then the understanding and abiding by the clinical and cultural pathways for the witnesses. That means cultural and patient identification schemes, specialty physicians that are certified in some way internally, the order sets and phlebotomies and surgery booking slips and announcements, internal communications through the announcements, like I said, internal CMEs, subcommittees, we have all this, the intraoperative data record, the dashboard that's a representation of this, and the data analysis that goes along with that. Quality control of the program, meaning some type of mechanism for peer review or response to fallouts. Creation of hospital-based services. So the anemia management program is still a little bit weak on our side. That's one thing that we were talking about fleshing out some. Outreach through a website, community education newsletter, publishing, and so forth. So you get the idea. So at the very end, the conclusions I've already elaborated on those too much. So internal consistency is always a focus and needs to be a continuous focus. External consistency as it relates to the referral process from you to the program, or from a referring physician to the program, and not to send a patient to a physician. It really should come through the program because, as I said, everybody's not a true believer or a true practitioner in this regard. We love the idea of a strong relational network with the witness community, and that's something that we've worked on hard over the years. We would like to see a formal certification process. One question is, at what level does that happen? Does that happen through the witness community? Does it happen as a secular, completely different outside of the witness community? And I don't know that answer. It kind of maybe it's both. Certainly, one thing I've said is that the witness community doesn't advertise. It's even hard sometimes for advocacy, but that's an answer that has to come from within the witness community, I think. And then how does this get mainstreamed to involve patients that aren't witnesses? Because that, for the healthcare system, that's the big yield from this, would be to somehow be able to translate this into a strategy of practice for non-witness patients. Okay.